Okay, so this one I'm gonna kind of be combining coronary artery disease with eye, so because they kind of go hand in hand. So coronary artery disease, and let me draw just a quick little. This is a terrible drawing, but anyway. So, coronary artery disease is a disease of the arteries of the heart. So these are the actual, and we're going to make our heart arteries, let's make them a dark red. So these are actually the arteries that feed the heart. So these kind of wrap around, and of course this is not anatomically correct, but these are the arteries that wrap around the heart and feed the heart, because the heart needs blood just like anything else, right? It needs oxygen, it needs oxygenation, it needs nutrients, that kind of thing. So what happens is with coronary artery disease is that there's atherosclerosis in the coronary arteries. Okay, so atherosclerosis is plaque buildup. Normally, when we think of this plaque buildup, we're thinking normally cholesterol. So you're going to see a high lipid panel on these people. So like high cholesterol, high LDL cholesterol, which is the low density one. That's the bad one. Anyway, so you're going to see a high lipid panel on these people. Atherosclerosis of the coronary arteries. And what happens is that this causes angina. So a lot of people that have coronary artery disease, their main symptom is angina. This is the main one, right? So chest pain. And that chest pain is normally like a pressure, tightness, heaviness. Okay, so just think about people that have. Okay, just think about people that have angina. They're going to be clutching their chest, right? So they're pushing on their chest because that pressure, that tightness, that heaviness. So just think about somebody, grabbing their chest. They're putting pressure on their chest. That's what that symptom feels like. So somebody that's coming into the clinic with angina, they're going to be grabbing their chest. They're going to be putting pressure on their chest, and they say that the pain feels like pressure, tightness, heaviness. I don't know if that helps you. That helps me to remember. So that's the main symptom of cardiac or coronary artery disease. But there's different types of angina. So we've got 4 different types, and we're really going to focus on 3 of them. So you have stable angina. And the reason it's stable is because this one occurs, it occurs with a pattern. So it occurs with an expected pattern, and it's normally exercise, and of course I can't spell, exercise induced, or activity. So these people are going to say, I was walking, I was running, I was having sex, I was walking up a flight of stairs, that kind of thing, and my chest started to hurt. But it goes away with rest. it goes away with rest. And that's the key for stable angina, is that they have it and it goes away with rest. Now, some of these people, if they have a history of angina, they might have like nitroglycerin and stuff that they can take if the pain, continues on. They say if you take more than 3, you have to take one tablet every 5 minutes. If you have to take more than 3, go to the ER, because it's no longer stable at that point. So that's stable angina. It's exercise induced. It doesn't go with rest. Okay, now we're going to do unstable angina. That's the second. So 1 is stable, 2 is unstable angina. And that one does not follow an expected pattern. It does not go away with rest. And it lasts for more than 20 minutes. And that's really the big one, is if that pain lasts for more than 20 minutes, they've got unstable angina. And these people have to be evaluated further, especially if this is a new thing. They should really come into the doctor. They should get an EKG done. They should get labs drawn. A lot of times they'll get outpatient catheterizations, just so that they can visualize the coronary arteries and make sure that those occlusions are not, that those occlusions aren't something that they need to deal with. Okay. And then the third type that we're going to talk about is the Prince metal. So it's Prince metal angina. And this is not necessarily caused by atherosclerosis. It's not caused by that. It's actually just a vasospasm. It's pretty of the coronary artery. It's benign. It can happen to anybody. It doesn't really mean anything. And it goes away on its own. It resolves on its own. So it's really just transient with that Prince metal. And then the last one is microvascular angina. If you should go into, I don't really know too much about it, so I don't want to talk about it. So, you go in the book if you want to know about it. So those are the 3 types of angina. And what causes this angina? So basically, like anything else, the heart is fed by vessels, and it's innervated, right? So it has nerves. When these vessels are not meeting, the requirements of them, so when they're having ischemia, they send out messages to the nerves, and the nerves cause pain. So that pain can radiate. Those nerves can, because we don't have one nerve for one thing. One nerve does several things. So that's why that pain radiates. And a lot of times that's those symptoms. The pain's going to radiate to the neck, the lower jaw for a lot of women. The left arm is the most common. It can be epigastric pain, which a lot of times people come in and it feels like they're having heartburn, and it's like a heart attack or just angina. And then very rarely will it be the back, but that can be rare. And a lot of times women are the one that are presenting with these like quote unquote strange areas of radiation. Men, it's normally going to be the chest pain, the chest pressure, the left arm. Women are really the ones that are like, oh, my back hurts, oh, my jaw hurts, that kind of thing. So why does it do this? I said it was because of ischemia. So myocardial ischemia. Now the difference between, because there's a difference, there's myocardial ischemia, and then let's do down here, myocardial infarction. Okay, so what's the difference? Ischemia is reversible. So ischemia happens when oxygen demand, so O2 demand of the heart, so myocardial, oopsies. Here, let's draw a picture. I haven't drawn any pictures on this one. So let's draw a little seesaw. This is what causes, right, so we have a little seesaw. So for myocardial ischemia, remember this is reversible. Ischemia happens when the heart's oxygen demand is greater than the myocardial oxygen supply. So let's pretend that this is one of the coronary arteries, right? So I'll draw two of them. These are coronary arteries. We'll zoom in there. Those are coronary arteries, okay? And let's draw a little plaque in there. So this is kind of how they grade occlusions. So this one's kind of like a 50% occlusion. This is like a 50% occlusion because it takes up half of that vessel. So this is pretty occluded. Okay, so let's say, I'm out running a lap or whatever. My heart rate is going to go up. So that's my heart rate. When my heart rate goes up, my oxygen demand goes up. Okay, so I'm out. I'm running a marathon, which I would never do. So when that heart rate goes up, when the oxygen demand goes up, and remember these are the coronary arteries, right? So these are the arteries right here that are feeding the heart. So they're feeding the heart. Just like any muscle, right? I need more oxygen. My blood vessels are going to dilate. They're going to dilate so that they can feed me more oxygen, more nutrients. They're going to dilate. Okay. So normal coronary arteries, they can accommodate this increase in oxygen demand because they just dilate and I get my blood flow. Now, if I have an artery that's like this, okay, I'm going to dilate, right? But I'm not going to get my normal blood flow. You see that? I can only fit 3 arrows in there. Here I could fit 1,700. So you can get way more blood flow when it's open like that. So this right here, right there, that's what causes the ischemia. Because my demand is greater than the supply, right? Because I'm not getting enough supply right here. I'm not getting enough. There's not enough room. So that's what causes ischemia, right? And then infarction is irreversible damage. Is damage to the myocardium. So what happens is, and with infarction, it's going to be either 100% occlusions, so there's absolutely no blood flow going at all. And remember, these are the cardiac arteries that I'm drawing here. So with infarction, there's either going to be 100% occlusion. So there's absolutely no blood flow. And then this becomes necrotic. So this tissue right here, that becomes necrotic. It's dead. It's dead tissue. D-E-D. D-E-D, dead. No, I'll write it so that I don't. So that's dead tissue. And that that's 100% block. And that 100% block, that's what's a STEMI. And we'll go into that in a little bit. Or it could be just partial occlusion, right? But it's still pretty severe. So that's like 75% occlusion. So there's still room for the blood to go. However, if it continues this way, there will eventually be some necrosis. It's not going to be as mass and as severe as the STEMI over here. So this could cause a non-STEMI or unstable angina. Okay. Which unstable angina and STEMIs, non-STEMIs, have pretty much the same presentation. So you're probably like, okay, Gabby, so you're telling me they have the same presentation. How can you tell the difference? Like, how can you tell if this is something that you can just like send them home with, or do they need to be admitted to the hospital? Well, with it's simple. You do a cardiac panel. Okay. Because the non-STEMI is acute and angina is normally chronic, the troponin, the cardiac enzymes, will be elevated faster. So with angina, the cardiac enzymes will elevate, but it'll be after a few days. And normally after the episode. Normally after the episode is done. Okay? With a non-STEMI, because it's acute, you're going to see an increase in cardiac enzymes within a few hours, right? So it's going to be pretty rapid. The one that we look at, like the gold standard for non-STEMIs, STEMIs, that kind of thing, is troponins. That's like the most cardiac specific enzyme, because we have like the myoglobin and that kind of stuff, but any muscle that is having ischemia will release that enzyme. Troponin is the more cardiac specific. So I'm kind of jumping all over the place, but so that's infarction, and we'll come back to that in a second. So how would you diagnose, or what kind of diagnostic tests would you do? Actually, you know what? We'll continue with an MI, because the cardiac, the diagnostics are the same for both. So let's just continue with the MIs. So we already talked about non-STEMI and STEMI. I've already discussed that. So we already talked about non-STEMI and angina. So let's talk about a STEMI. What is STEMI? Everybody knows what an EKG looks like. So you've got your QRS, your T wave. Okay, so this is your P, Q, R, S, and your T, right? And then this is your PR. This is your ST segment. So this, let's do a different color so we don't get confused. this is what we're looking for. That ST segment, that's what we're looking for with to determine on the EKG if it's a STEMI or non-STEMI. So ST elevation will look like and again, excuse my poor drawing skills. So it'll look like that. There's the ISO. Oopsies. I don't really like how I drew that. Let's try again. Like that, okay? So that ST segment is going to be elevated way above the isometric line, right? So that's how you can tell if it's a STEMI. Now, when we do a EKG, it's a 12-lead EKG. So we get to see different views of the heart. Not every single lead is going to have ST elevation normally. Normally you're going to have it in like 2 or 3 leads, and depending on where the ST elevation is will tell you where your infarction is happening, whether it be lateral, septal, right ventricle, left ventricle, posterior, anterior, that kind of thing. And I didn't mention this in the heart failure video, but anterior MIs can lead to heart failure, because when we're talking about the anterior wall of the heart, we're talking about that ventricle. Usually it's mostly on the left ventricle, and if there's any kind of infarction there or tissue death, obviously we're going to have some heart failure going on, because dead tissue is dead. You can't revive it. It's not going to work the same anymore. It's going to scar up, that kind of thing. So an anterior wall MI can also cause left ventricular heart failure or left-sided heart failure. Anyway, so the leads tell us where our MI is, and you have to have it in 2 contiguous, and this might be going too much in depth, but 2 contiguous leads, which means that both of those leads have to be looking at the same side of the heart. So, you're not going to have one in the right, in the lateral, and then one in the septal. They have to be looking at the same place for you to be able to diagnose a STEMI. With a STEMI, your troponins are also going to be elevated. Your cardiac enzymes, your markers will be elevated. So, yeah. That's pretty much that. So STEMI is an emergency. You got to quickly get them into the cath lab for a PCI. It's an emergency for STEMIs. Just like what they say with strokes, time is brain. With the heart, time is muscle. If you have a STEMI, immediately send them to the ER to get a catheter or PCI. PCI is percutaneous intervention. So this is when they can place stents. This is when they can do like balloon angioplasty, all that kind of stuff. And again, that's going a little too in depth, so I'll just leave that alone, and you guys can look into that yourself if you want to. So let's go diagnostics, and let's do a different color. So we'll do diagnostics. Diagnostics for both of these would be a stress test. Well, I say both, but not for STEMIs. For STEMIs, really, we just look at EKGs. But for non-STEMIs, unstable angina, that kind of thing, we're going to look at the stress test, EKG, lipid, and BMP, so like the blood tests, lipid panels, BMPs, and a lot of times we can also do like a catheter. I'm just going to say cardiac cath because I can't spell catheterization. Cardiac cath, and doctors will do like these exploratory cardiac caths. They could be outpatient, and that's just to see the level of occlusion that there is, because at any point that plaque could rupture or break off or migrate into a smaller vessel of the artery and create or cause an MI. So even though, let's say for this guy right here, he's only 50% occluded, this could be like a major artery like the LD or the LAD, which is one of the biggest coronary arteries. But if this plaque decides to separate and rupture and travel down to a smaller vessel, it could completely 100% occlude it and cause an MI. So doctors often like to see, where that is. So let's look and see if I'm missing anything for this. So, okay. So like I said, cardiac cath is the test that we want to do. This is the gold standard for diagnostics for coronary artery disease. If the stenosis or the plaque is greater than 50% in a main artery, so the LAD, the RCA, that kind of thing, or greater than 70%, oh no, wait, 50% of the LAD, so the left, I'm reading from the common core thing, the common conditions. The left main coronary artery, or 70% of the other arteries. Main arteries. That's what diagnoses CAD. So greater than 50% of the left main coronary artery and greater than 70% of the other arteries. Now, let me see if I'm missing anything for MIs. Oh, they want you to know, it looks like they want you to know how many hours after onset of chest pain will the cardiac enzymes elevate. Troponins will elevate 3 to 6 hours after onset and can remain elevated for 7 to 14 days. The CKMB is 3 to 4 hours after onset, and the myoglobin is the earliest marker for MI, which is 1 to 4 hours. But like I said, myoglobin is not very specific, so we really want to look at troponins. So troponins will elevate within 3 to 6 hours after onset. CKMB is 3 to 4 hours, and the myoglobin is 1 to 4 hours after the onset of chest pain. A lot of times in the hospital, I don't know if I should even say this, but in the hospital we'll see that troponin increase after the cath and after that stenosis is gone, like after the angioplasty, just because we went in there, we messed with the heart got a little irritated. So it's normal to see troponins increase after a PCI, but we should start to see them decreasing drastically afterwards. Remember that risk factors for an MI, of course, atherosclerosis, increased lipids, diabetes, stress, hypertension, and tobacco use. Diabetics, and remember this because I'm sure it's going to be on some kind of test. Diabetics, so diabetes mellitus causes silent MIs, okay? So diabetics will often come in to the clinic or wherever, get an EKG, and we see signs of a previous MI, and they're like, oh, I've never had a heart attack. Diabetes causes silent MIs. Now, another thing that we probably want to know is, how do we know that they've had a previous MI? How do we know? We can't see the necrosis of the heart. When we're doing a 12-lead EKG, let me see if I've got any more room. When we're doing a 12-lead EKG, we, let me see, let's do a different color. Pathological Q waves, equal a previous MI. Okay? So the way that it kind of works is initially, somebody's texting me. So initially, you're going to see, here's the regular, EKG waveform. You're going to see, that ST elevation, right? And then we're going to fix them, whatever, blah, blah, blah. And then you're going to see what's called a pathological Q wave. So after everything's fixed, so right here, let's do a different color so you can see. Right here, that's a Q wave. And a Q wave, like I said, signifies a previous MI. So, on some people, it's normal to see a Q wave, and that doesn't mean that they've had an MI. But how do you know if it's just a regular Q wave or if it's a pathological Q wave because of a previous MI? The Q wave will be half of the R wave. Okay? So the R wave is this right here. Okay? So this Q wave will be half the length of the R wave, and that's how you know that it's a previous MI. Now, there's you could get really down into the nitty gritty, and it's the amplitude is 0.5 seconds or whatever, but you just have to remember it's half of the R wave, and that's how you know. As always, if you have any questions, first of all, please remember that I am not a teacher. This is just how I remember things. Just because I said it on this video or I wrote it down doesn't mean I'm right. Always check me, please. But if you have any questions or need me to explain something a different way, just let me know. I'll put my phone number on here like I will do for the rest of my videos if these help. Just let me know if you need anything. All right, goodbye.